Good evening. Welcome to this Ask the Expert event focused on gastrointestinal cancer, from diagnosis to treatment and survivorship. Tonight, in honor of Gastric Cancer Awareness Month, a panel of experts will share crucial information about prevention, early detection, and support for those diagnosed. We will also answer your questions live. To submit a question for our panel, simply drop it in the chat here on Facebook. Let's meet our panelists. First, we have Dr. Jeffrey Pelton, board certified by the American Board of Surgery with additional fellowship training in complex surgical oncology and endocrine surgery. Dr. Pelton is joining us today from Mary Washington Healthcare. Next, we have Dr. Bonny Moore. Dr. Moore is board certified in hematology, oncology, and internal medicine with Hematology-Oncology Associates of Fredericksburg. In addition, we're pleased to welcome Dr. Amandeep Kalra, a board-certified and fellowship-trained gastroenterologist with Gastroenterology Associates of Fredericksburg. Welcome, and thanks for joining us this evening.
Thank you.
Dr. Pelton, I'd like you to start the program. Gastrointestinal cancer, or GI cancer, is kind of unique because it covers more than one tumor location. Can you give us an overview of GI cancers and why raising awareness about them is so important?
Yes. So the gastrointestinal organs are the organs of digestion. So these are the organs that process what we eat and what we drink. And you can see listed there, starting up at the esophagus, which is the food pipe. So food enters down through the esophagus into the stomach, into the small intestine, and then it's processed through the small intestine into the colon, and then eventually the waste is passed through the rectum and anus. There are other organs that contribute to that by making enzymes and secretions that help digest the food, and that includes the pancreas, the liver. Some of the bile from the liver is stored in the gallbladder and passes down the bile ducts. And those organs are also part of the digestive system. The appendix is a vestige organ. It's part of the digestive tract, but it really doesn't have a function anymore, but it could still get cancer and is considered a GI cancer. The term cancer is very broad, and it helps a little bit to understand that term. There's basically two large groups of cancer. There's what are sometimes referred to as the blood cancers. That includes things like leukemia and lymphoma, which occur in blood and lymph nodes. But it's worth noting that some of these gastrointestinal organs can also get lymphoma, which is considered a blood cancer, and it's treated completely differently than the other group, which are solid organ cancers. And that's more what we're talking about here with the GI system, are solid organ cancers. These are all solid organs. And of course, there are other solid organs in the body, like the lungs and the brain, etc. But these are the GI organs are all solid organ cancers. And then each organ within that system can have many different types of cancer. So the stomach has a certain set of cancer, the liver has a certain set of cancer, etc. The most common type of GI cancer is called adenocarcinoma, and this has to do with where the cancers arise, what cells they arise from. Adenocarcinoma is the most common. But there are others. There are things called neuroendocrine tumors. There are gastrointestinal stromal tumors, if they're of the malignant variety. And then, as I mentioned, some of these organs can get lymphoma. But the most common, when we're talking about GI cancers, we're most commonly talking about adenocarcinomas. It's very challenging to treat some of these because these have to be treated in a multidisciplinary fashion, usually. That's why you see several panelists up here. It's treated generally with some combination of surgery, chemotherapy, or systemic therapy. Sometimes radiation therapy fits into it too. So that just gives you a little overview of GI cancer. Now, what else makes it important is these cancers can sometimes be challenging to diagnose because they live in the abdomen. And the abdomen actually comes from a Latin word that means hidden. So some of the symptoms of GI cancers can be very vague. And therefore often will present later, and we'll talk about that a little bit later on in the program. But the key to curing the solid organ cancers is to try to diagnose them early. And that's where you see screening, which our gastroenterologist will talk about. So early diagnosis is very important. Warning signs of these can be vague, sometimes just vague abdominal pain, sometimes unexplained weight loss. But if these kinds of symptoms occur persistently for probably around 6 weeks or so, you should probably go get an abdominal imaging or see a specialist about getting diagnosed. So that gives you a little bit of an overview about GI cancers and how we approach them.
Wonderful. Thank you, Dr. Pelton. And Dr. Moore, Dr. Pelton touched on this a little bit, but can you tell us more about GI cancer treatment options and how they are approached and customized to the unique needs of every patient?
Yeah, so just to echo what Dr. Pelton said about, different, it's a multidisciplinary approach for sure. And figuring out if a patient needs systemic therapy, radiation, surgery, or a combination of all three of the above. Um, we base the treatment recommendations based on the patient's location, the tumor location, what organ system, what stage it is. And most of these are staged based on the tumor size, the tumor invasion through the layers of the digestive system, if lymph nodes are involved, or if there's any distant spread of the disease. But also, really in the last few years, and even this year, there's been multiple kind of new studies that have come out with immunotherapy and targeted therapy. So that's the other part that really plays an important role in treating a patient, is knowing what their particular tumor, what the genetics of that tumor hold. And we're seeing some patients with colorectal cancer, for example, that don't need surgery or radiation or chemo. They get immunotherapy alone. I mean, it's a smaller portion of patients, but that's exciting that there's been those advances in targeted therapy.
That's wonderful. Thank you, Dr. Moore. Dr. Kalra, let's talk about screening a little bit. What roles do screenings play in GI cancer, and what should our viewers keep in mind about these tests?
Yeah, thank you for that question. Thanks for having me on board. So GI cancers are one of the leading causes of cancers in the US, as we all know. And the biggest important thing to remember is there are only few cancers we can screen for, and GI gastroenterology cancers are one of them. And as Dr. Pelton mentioned earlier, it can involve from anywhere from your mouth to anus, and there are some organs which help with that. The most important cancer I want to talk about today, which has made a big difference in United States, particularly, is colon cancer. So screening for colon cancer has made a robust difference, in diagnosing these cancers early, not just diagnosing these cancers also early, but also when we do colon cancer screenings, we can see the polyps and remove them, and that decreases the risk of colon cancer. Now, to elaborate that on further, there are different screening tools for colon cancer screening, and most of us know number one and gold standard is colonoscopy, and we do this here in Fredericksburg and Stafford. It's one of the gold standard for colon cancer screening. It just doesn't help in diagnosing the cancers, as I said. It also helps in removing those polyps, which decrease the risk of colon cancer. And apart from that, there are other screening modalities available. If somebody doesn't want to do a colonoscopy for whatever reason, I would still encourage them to talk to their primary care or gastroenterologist for other screening modalities. There are other screening modalities available. For example, Cologuard. It's basically a DNA-based test in the stool, which helps in detection. Now, you have to keep that in mind. You can have many false positive or false negative results from that, and it can miss smaller polyps. It's not very good in diagnosing polyps less than 10 millimeter in size, and those polyps can turn into cancer. So, but it's definitely out there. If somebody doesn't want to do colonoscopy, that's there. The other test is FIT test, which is also DNA-based test in the stool, which is recommended to be done every year if you're doing that. And for Cologuard, it's recommended every 3 years. But colonoscopy, I want to talk a little bit more about that. It's recommended right now, 45-year age or older. And once you get the colonoscopy, based on your risk factors and based on how many polyps you have and what kind of polyps you have, we recommend screening interval. That's 3 years, 5 years, or even 10 years. And very important to talk to your primary care or gastroenterologist about the risk factors. And one of them is family history, and family history is really important when it comes to gastrointestinal cancers and some genetic syndromes. And we'll talk about that in coming time as well in this program. But genetic syndrome is one of them. And that's where our primary cares and other physicians can help us, if somebody has strong family history, to help them with genetic testing. Now, not just colon cancer. I want to also talk a little bit about other cancers. For example, esophageal cancer. It's not uncommon cancer. It's common in patients with chronic acid reflux. And a matter of fact, if they have bad acid reflux, they can have something called Barrett's esophagus, which can put them at risk for esophageal cancer. And we can decrease their risk by treating that Barrett's esophagus. There are different ways to treat that. Apart from that, as we know, there are other cancers which are rising in the community nowadays, and pancreatic cancer is one of them. And not just that, because of increase in fatty liver, there is a lot of liver cancers we are seeing nowadays. But there are some screening tools available for those as well, especially in high risk patients. We do ultrasounds of their liver every 6 months, and then for pancreatic cancer, if there's a high risk patient who has genetic predisposition, we can always do imaging, or we do an endoscopic ultrasound at Mary Washington Hospital and Stafford Hospital, which helps in diagnosing them early on.
That's wonderful. And we actually have a follow-up question. So regarding family history, how close of a relative is relevant? Is it parent or sibling, or would a grandparent also count?
A very good question. So the most important is first degree relative, actually, but definitely we do get into consideration if there are multiple second degree relatives, but first degree relative is really important. And Dr. Moore or Dr. Pelton can also, we can ask them in coming time. But main thing is family history. But the other thing which I want to talk about is genetic cancer predisposition, like Lynch syndrome, and there are entities like familial adenosis polyposis, where patients just not at risk for colon cancer, but they're at risk for other cancers. And for example, endometrial cancer, for stomach cancers. And not just that, but genitourinary cancer and breast cancer. So there's that thing to keep in mind. But to answer your question, first degree relative is more important. But if there is multiple relatives involved, we should keep that in mind to screen these patients for genetic mutations, and that changes the whole thing, because these patients need to be screened in their 20s, 30s, and maybe if you have familial adenosis polyposis, you need to be screened at the age of 12.
Wow, that's fascinating. Thank you so much, Dr. Kalra.
So I would add that the geneticists and the genetic counselors would say that a familial cancer, in other words, one that is occurring with genetic mutations across family members, generally requires a first degree relative, and then similar cancers or clusters of cancers across several generations. That's what the genetic counselors look for when they're screening for familial related cancers. Most cancers are sporadic. We still screen for those, but there's a subpopulation of familial cancers.
Absolutely. And 5% of colorectal cancer are familial, as you mentioned. 95% are sporadic, and there's a high rise in this in younger population, and I'm sure we'll touch that in coming time as well.
Yes, thank you both so much. Dr. Moore, let's discuss lifestyle factors. What are some things that patients can do to lower their risk of developing GI cancers?
So not smoking. I think a lot of times we think of smoking associated with lung cancer, but smoking also increases your risk for esophageal cancer, for stomach cancer. So not smoking, limiting alcohol intake. Alcohol intake increases your risk of stomach cancer and some of the other GI cancers as well. Things we talk about, fruits and veggies, right? The good things, but I think one of the things we don't talk about, we talk about avoiding red meat or limiting red meat, which is maybe part of it, but also limiting processed meats like deli meats and cured hams, that kind of thing. Those, from a lifestyle perspective, put you at a higher risk of GI cancers, specifically colorectal cancers. And the other good things we talked about, exercise and that kind of thing. And then just to echo on what Drs. Pelton and Kalra said, that, really taking a lead on your family history and knowing what doors that opens for you, because a lot of times there's high risk clinics, there's additional screenings that you just automatically get qualified for, which just because of your family history, and being able to know that genetic piece of what you're at risk for.
Yeah, thank you, Dr. Moore. I'm glad you said that, because I wouldn't have even known that you would automatically qualify based off of your family history. So there's resources for people who have family history. Thank you. Dr. Pelton, could you tell us about the surgical options available for GI cancers and what patients can expect during recovery?
The surgical treatment of cancer in general is done for solid organ cancers. So I mentioned lymphoma can occur throughout any part of the gastrointestinal tract. That's treated completely differently, almost never surgically. There are some rare situations, but usually treated with systemic therapy like chemotherapy, immunotherapy, and sometimes radiation therapy is added. But given that these are largely solid organ cancers, the general principle behind treating these diseases surgically is to remove the cancer with a wide margin as possible of normal tissue around the cancer, and also to remove lymph nodes in the area. Lymph nodes filter the bloodstream through the lymph system. They act as little filters. And so often when a cancer from a solid organ gets on the move and starts to get out of the organ, the first place it sometimes goes is into these little filters called the lymph nodes. And so surgical resections for GI cancers include removing the part of the organ that contains the cancer and some of the surrounding lymph nodes. Now, sometimes the entire organ has to be removed. In certain cases, for example, of advanced stomach cancer, it may require removing the entire stomach. There are cases in familial cancers of the colon where the entire colon has to be removed. But in general, we remove the part of the organ that contains the cancers and the surrounding lymph nodes. And then we often have to put things back together again. If we remove part of the stomach, we have to rehook things up. Same thing if we remove the colon, we have to hook it back together again. So that's generally what happens with surgery. Now, the approaches to surgery have changed quite a bit over the last couple of decades. The traditional sort of conventional approach is what we would call an open operation, which involves an incision up and down the abdomen usually. Sometimes the incision can be kind of long. Sometimes it goes sideways depending on which organ's getting operated on. But it involves an actual pretty long incision on the abdomen and then actually going into the abdomen and performing the surgery. There have now been a lot of technical advances using what's called minimally invasive surgery, where the abdomen will be entered either with small ports and a camera and instruments that then can be used to perform the same operations. So the operations that are going on inside the abdomen are the same whether they're done open or whether they're done by one of these minimally invasive approaches. So laparoscopic approach is one, and now the robot is making its way into abdominal surgery. It had been shown to be very advantageous in more confined spaces like the chest and the pelvis, but with advances in technology now, there are more of these operations done robotically. So those are the approaches: open, minimally invasive, which includes laparoscopic and robotic. One of the advantages to the minimally invasive approaches is that the recovery times are a bit faster. The incisions are smaller. A traditional open operation will usually require about a 1-week stay in the hospital, sometimes up to 2 weeks, depending on which organ is getting operated on. Sometimes in certain cases, we have to make stomas where the intestine is brought outside the abdomen for a while or permanently, depending on the situation. And the stool then has to collect into a bag. So the operation is tailored to exactly what needs to be done to remove the cancer. The recovery, as I mentioned, for an open operation, anywhere from about 1 to 2 weeks. Minimally invasive approaches get that down to sometimes anywhere from about 3 to 5 days. And some of that has to do with return of bowel function, which can vary a little bit from individual to individual. I tell most patients that if they're going to have a major abdominal operation for cancer, generally it takes about a good 6 weeks for them to fully recover, get their energy back, and do anything that they wanted to do before. And then once they're recovered from the surgery, within about a 4 to 6 week range, they may go on to get additional treatment from Dr. Moore and her colleagues, and possibly sometimes from radiation therapy, and that's tailored to the individual patient.
Wonderful. Thank you so much. And we're actually going to jump into our live question and answer session where we'll be answering questions from our audience because we have a lot of questions coming in, which is very exciting. So the first question, Dr. Kalra, is lymphoma hereditary?
Uh, so lymphoma is mostly sporadic. And I will actually bounce that question to Dr. Moore as well. But yes, I would say lymphoma is mostly sporadic. Yeah.
Dr. Moore, did you have any?
Yeah, so there are some genetic conditions that put you at higher risk for lymphoma. Yeah, most of the time it's sporadic, but there are some genetic mutations that increase your risk. Lymphoma isn't something that we typically, it's not something we screen for. There's not a good screening tool for it, but yes, occasionally hereditary.
Thank you so much. And Dr. Kalra, we have another question for you. For patients that have existing acid reflux and are being treated for medication, are they supposed to get re-examinations and further endoscopy work to see if there's further symptoms?
Very good question. I think recently there's been a lot of literature out there. They talk about PPIs particularly have higher risk for osteoporosis and a lot of other things they talk about, even dementia. So the question is, do these patients need to be on PPIs? So I think that's a very good question. The answer to that question is, you need to, if somebody doesn't has Barrett's esophagus and we can manage them with lifestyle modification. That's my primary goal. I believe in prevention, better than cure. Of course, when we need cure, we definitely need that. But try to prevent. Prevention is better than I would say. So the first thing I would say is I try to change the lifestyle if they can. As Dr. Moore was saying, dietary modifications. Not eating late dinner. Eating 3 to 4 hours before going to bed. Simple things like less fried food, avoiding triggers like alcohol, chocolates, stuff like that. And we can many times get them off medications. I think that's what my goal is. But if they do have Barrett's esophagus, which is an entity can increase your risk for esophageal cancer, then there is a recommendation that we do endoscopies minimum every 3 years. And if they have precancerous cells, then it has to be every year or so. So yes, it all depends, what symptoms you're having and if we can get that symptoms away or not, and what condition you have apart from acid reflux. Do you have Barrett's esophagus or not?
Wonderful. Thank you so much. Dr. Moore, on average, what is a life expectancy of stage 4 colon cancer with also some is also spotted in some of the lymph nodes in the chest area?
So it on average, patients with metastatic or stage 4 colorectal cancer tend to do well. Usually we're talking in terms of years. I have some patients that have had stage 4 from diagnosis that are 7-8 years out from their diagnosis. That's an average, so some patients won't do as well and may not have that that long of a lifespan, but that the average has moved over the last over the last 10 years and has increased greatly. So I can think of many, many patients of mine who have had, if you saw them on the street, wouldn't know that they had cancer and wouldn't know that they had stage 4 disease. So.
That's amazing. Hopefully someone can sleep a little bit better tonight.
And just if I could add to that from my own experience, because I've been doing this for over 30 years, and I can say when I first started, there was only one medication. It was basically modulated 5-FU that was used for colon cancer. And in those days, stage 4 colon cancer had a really dismal prognosis. It was rare that anybody made it beyond 3 years. But there's so much more now, and so many other treatments, chemotherapy, immunotherapy, and this whole field of molecular oncology that Dr. Moore had alluded to earlier, that tailors targeted therapy, that now stage 4 colon cancer patients get, they can get years. They can definitely get years. Yeah.
And, one of the cool things is seeing the chain, like seeing the number of targetable drugs that are developing, right? And the crossover between tumor types. So, HER2 is a protein that we originally were targeting in patients with breast cancer. And now, we're targeting it in patients with different gastrointestinal cancers, or with KRAS, with lung cancer, and we have there's clinical trials looking at that in patients with GI malignancies, and the people with BRCA mutations, and the list goes on. So getting to that more targetable, individualized treatment for each specific patient and what their tumor looks like has changed dramatically. And of course, immunotherapy has been probably one of the most exciting. That immunotherapy was kind of starting at the beginning of my career, and seeing the number of cancers that we can treat with that is huge.
That's incredible. Thank you. And Dr. Pelton, back to you. Is there anything you can share with our audience about adult rectal prolapse intussusception?
Well, that's not typically associated with cancer per se. So that's a situation usually of laxity of surrounding tissues around the rectum, where the rectum then begins to prolapse. And in milder forms, that's generally doesn't require surgical intervention, but if the prolapse is severe enough, then a colorectal surgeon has a couple of procedures they can do to correct the prolapse, but it doesn't necessarily lead to cancer.
Okay, wonderful. And another question for you, Dr. Pelton. Can Barrett's esophagus go away with medication and lifestyle changes, or once you have it, does it remain?
Well, that's a very complex topic, because the diagnosis of Barrett's esophagus often gets broken down into what is called the degree of dysplasia, which are the types of changes in the cells that a low-grade dysplasia, for example, looks more like normal cells, but still abnormal, whereas high-grade dysplasia is now starting to look like cancer. So there are situations where the degree of dysplasia can depend on treatment and on severity of the disease and longevity of the disease. The changes, though, tend to persist, but cases of low-grade dysplasia can be followed for a very long time, especially if the reflux is treated. And that's usually more in the purview of the gastroenterologist. But it generally, it's always there. It's just, it has to be managed, and it's very important that it's screened for.
I would agree with Dr. Pelton. Yeah, so it persists, but yeah, so it doesn't go away, but you have to treat the acid reflux. That's what will decrease the risk of esophageal cancer, basically.
And in the very high degree forms of high grade dysplasia, though, if that persists, that's when, even though it hasn't progressed to a frankly invasive cancer, the surgeon will often be called in to resect the disease, because there may be hidden cancer in there, or it's very close to becoming a cancer.
Absolutely.
Wonderful. And then, Dr. Kalra, we'll have one last audience question, then we need to wrap it up for the night. But we kind of touched on this a little bit earlier, but if someone has early onset family history of stomach cancer, is there any lifestyle changes or anything they could do to help prevent a possible diagnosis?
Yes. So lifestyle is really important. And so always think about GI cancers, why they're common nowadays, because we are living in different lifestyle than our ancestors 100 years ago, right? So the biggest thing you want to think about is diet. As Dr. Moore was saying, diet is the most important thing. Staying away from processed food is the key. I mean, trying to stay away from processed food as much as you can. Of course, we can't get rid of it completely because, of our day-to-day life, but that's number one thing I would recommend. Limiting the use of alcohol. Alcohol is the number one, maybe not number one, but one of the leading causes of GI cancer. So limiting the use of alcohol. The third thing is trying to be more active. The more active you are, the better you will do in terms of not having these cancers. So diet in terms of avoiding processed food, avoiding alcohol, limitation of red meat. And if you got to eat red meat, try not to get something which is frozen for like 30 days. That's going to have nitrosamines in that. So as I said, go back what our ancestors were doing 100 years ago. They were getting it from the fresh farms, stuff like that. So they're not in the freezer for like 30 days and then you're using it. So that's the most important thing.
Wonderful. Thank you so much. And we're getting close to the end of our time tonight. Thank you to Dr. Pelton, Dr. Moore, and Dr. Kalra for sharing your insights and expertise tonight. And a big thank you to all of you, our viewers, for tuning in to this Ask the Expert event. Remember, Mary Washington Healthcare offers a range of resources for those diagnosed with a GI cancer, including access to specialized care, screenings, and support services. We invite you to visit us online at cancer.mwhc.com and be sure to watch the Mary Washington Healthcare Facebook page and other social media channels to stay informed of the latest health and wellness information for our community. Please join us at the same time, 6:30 next month on December 9th, for another Ask the Expert. The topic will be Give the Gift of Health. It'll cover preventative screenings, imaging, our oncology nurse navigators, and more. Until then, stay safe and healthy and have a good night.
Thank you.
Thank you.